Good morning everybody. Welcome to the lecture on the hip joint in module 1. In this lecture, we will be discussing the structure and function of the hip joint and the common problems of the hip joint. The hip joint forms the primary connection between the bones of the lower limb and the upper limb. It is a synovial joint and the articulation forms a ball and socket joint as shown in the figure. The hip joint consists of the femoral head, which is the ball, and the acetabulum, which is part of the pelvic bone and is regarded as the socket. So, the hip joint basically is an articulation between the femoral head and the acetabulum. As shown in the figure here towards the left and in the sectional view of the hip joint here in this figure. Now, I am showing you a composite femur, which is a femur very similar in structure and geometry of the actual femur. You can see here the femur bone consists of the head, femur head, the neck, the greater trochanter and the lesser trochanter. We are moving towards the posterior view. So, we have the condyles, the two condyles of the femur at the distal end. Now, this proximal part of the femur actually consists of the head, neck and the trochanters. The main body of the femur is the femur shaft and it is connected to the distal part of the femur, the medial condyle and the lateral condyle. Now, the femur head actually articulates with the pelvic bone within the acetabular cavity or the acetabulum. As you can see, the pelvic bone is also a large bone, and clearly as I hold the structure, the plastic or composite bone structure, you can see the inside of the acetabulum here. This is where the femur head articulates within the hip joint and forms a ball and socket joint. The articulating surfaces of the hip joint consist of the femoral head and the acetabulum. The femoral head spans around 2/3 of a sphere. It is covered by a hyaline cartilage except the fovea of the femur, a small depression which is known as the fovea capitis. The figure on the left presents the head of the femur with the fovea small depression and the acetabulum or the acetabular cavity of the pelvic bone. Now, the acetabulum, which is the socket, is a horseshoe shaped articular surface covered by hyaline cartilage. It is a deep notch with a narrow mouth as shown in the figure. It is part of another large bone, which is the pelvic bone. So, acetabulum is indicated here in this figure. Now, let us discuss about the functions of the hip joint. The hip joint is a major load bearing joint. The primary functions are to support the body weight in both static and dynamic postures. Static, for example, standing and sitting, and dynamic, for example, walking and running. The other functions are to facilitate transfer of forces and moments. Basically, we call it load transfer from the upper part of the body to the lower extremities. To enable a large range of movement and maintain stability during these movements, to retain balance and to maintain the pelvic inclination angle. The effect of the pelvic tilt angle on the height of a subject is shown here in this figure for the normal case and for the anterior pelvic tilt. So, it is observed that for an anterior pelvic tilt, there is an effect on the height of the subject. Now, let us discuss about some hip deformities. The eminent among those are the varus and valgus. Before we discuss about varus and valgus, we should define what is the femoral neck shaft angle. Now, the femoral neck shaft angle is the angle between the longitudinal axis of the femur neck and shaft. It is also called the CCD angle and normally measures for newborn child 150 degrees and for adults it is about 126 degrees. So, this is the normal condition between 120 to 135. The neck shaft angle corresponds to a normal condition. Now, for a varus deformity, the neck shaft angle is reduced to less than 120 degrees. This results in shortening of the leg and development of limp, asymmetric abnormality of the gait. On the other hand, the valgus is the condition where the neck shaft angle is increased. As you can see in this figure, it is usually greater than 135 degrees. The other hip deformities are anteversion and retroversion. Here also we need to look into the femoral neck anteversion angle. So, it is the angle between an imaginary transverse line oriented along the medial lateral direction through the knee joint and an imaginary transverse line oriented through the center of the femoral head and the neck. So, the angle between these two imaginary transverse line is known as the femoral neck anteversion angle. The normal range is between 15 to 20 degrees. For an increased neck anteversion, angle is greater than 20 degrees, whereas the opposite of anteversion is retroversion, in which the angle is less than 10 degrees. So, you can observe the deformities very clearly with regard to the normal situation. Let us now discuss about the muscles of the hip joint. The muscles of the hip joint consists mainly of 4 main groups. The 4 main groups are the abductor, iliopsoas, gluteal and lateral rotator. Within the abductor muscles, we have the abductor group of muscles, the abductor brevis, abductor longus, abductor magnus, pectineus and gracilis. So, these are the main 4 groups of muscle acting on the hip joint. The other muscles are hamstring, rectus femoris and sartorius. Let us discuss about the movements offered by the hip joint and the muscles responsible for each movement. The movements in the hip joint along with the range of motions and the muscles responsible for the movements is indicated here. The maximum range of motion is indicated within brackets as shown here for flexion and extension, and the muscles responsible for the movements are listed beside each figure that represents a particular movement. Now, the hip joint offers quite a variety or large range of motion. The flexion and extension is one or two such movements. The maximum angle of flexion is 140 degrees and the maximum angle for extension is relatively less, that is 20 degrees, around the transverse axis in the sagittal plane. So, this is measured in the sagittal plane as shown in the figure. The flexion is moving your leg forward and extension is moving your leg backwards. The flexor muscles responsible for the movement flexion is indicated on the left hand side of the slide, whereas the extensor muscles that is responsible for the movement extension is also indicated here in the slide on the right hand side. The other movements are external or internal rotation. External rotation is also referred to as lateral rotation. So, the maximum angle of rotation is 30 degrees with hip extended and 50 degrees with hip flexed. The external or lateral rotation is indicated in the figure here. As you can see, it is a rotation which is away from the midline of the body. Therefore, it is lateral rotation. The medial rotation is a rotation of the hip towards the midline of the body, and it is called internal or medial rotation. The maximum angle is 50 degrees rotation around the vertical axis in the coronal plane. The muscles responsible for the lateral or external rotations are listed on the left hand side beside the figure, and the muscle, about 5 muscles are responsible for internal rotations and these are also listed here in this slide. The other movements are abduction and adduction. So, abduction is raising the leg away from the midline of the body, whereas adduction is moving the leg inwards towards the midline of the body. For hip, we can have a maximum of 50-degree abduction with hip extended and 80-degree abduction when the hip is flexed. The angle for adduction is 30 degrees with hip extended and 20 degrees with hip flexed around the sagittal axis in the anterior posterior direction. The abductor muscles, the muscles responsible for the movement abduction is listed here in this slide, whereas the muscles, there is a host of muscles responsible for the movement adduction, and it is called the adductor muscles, are also listed here in this slide. The hip joint also provides the movement abduction and adduction. So, you can see the abduction is rotating away from the midline and adduction is rotating towards the midline. Now, the maximum angle of during abduction is 50 degrees with hip extended and 80 degrees with hip flexed. For adduction, it is 30 degrees with hip extended and 20 degrees with hip flexed. So, these angles can be measured around the sagittal axis, which runs along the anterior and to posterior direction. The abductor muscles are listed here, and the adductor muscles are also presented here in this slide. The ligaments of the hip joint play an important role in stabilizing the joint. The hip joint is reinforced by 4 ligaments, out of which 3 are extracapsular and 1 intracapsular. The extracapsular ligaments are the iliofemoral ligament, pubofemoral ligament and ischiofemoral ligament, whereas the intracapsular ligament is known as the ligamentum teres or the ligament of the head of the femur. This intracapsular ligament is attached to a depression in the acetabular notch and a depression on the femoral head, which is known as fovea capitis. It is a relatively small structure which runs from the acetabular fossa to the head of the femur. Let me show you the model of a hip joint. You can see the pelvic bone and the femur bone and the femoral head or the head of the femur inside the cavity, the acetabulum. The arrangements of the ligaments are shown clearly, that is holding the hip joint to offer stability to the joint. The iliofemoral ligament is also known as the ligament of Bigelow. It is basically a Y-shaped ligament. As you can see here in the anterior view, it is quite a thick band of ligament. It is the strongest ligament of the body and it resists the trunk from falling backwards in the standing posture. The upper and lower fibers form thick strong bands, while the middle fibers are relatively thin and weak. The pubofemoral ligament supports the joint inferomedially. It is a triangular shaped ligament adjacent to the iliofemoral ligament. The ischiofemoral ligament, the third one, is located on the posterior side of the joint. The ischiofemoral ligament consists of a triangular band of strong fibers towards the posterior side. The ligament tends to restrict internal rotation of the hip regardless of whether the hip is flexed, extended or in a neutral position. The ischiofemoral ligament is clearly shown here in the figure. Now, an important structure in the acetabulum is the acetabular labrum, which is a ring of cartilage that surrounds the acetabulum. This is clearly shown here in the figure. It is a fibrocartilaginous rim on the periphery of the acetabulum. It provides an articulating surface for the acetabulum, allowing the femoral head to articulate within the pelvis. It narrows the mouth of the acetabulum and it helps in holding the head of the femur in position within the acetabular cavity. The anterior portion of the acetabular labrum is vulnerable during labrum tears. Now, there is another ligament known as the transverse ligament of the acetabulum, a transverse acetabular ligament. It is a portion, the ligament is a portion of the acetabular labrum, but the ligament has no cartilage cells among its fibers. Now, let us summarize the factors that affect hip stability. The most important factor that affecting hip stability is the shape of the acetabulum. Due to the depth of the acetabulum, it can encompass almost 60 to 70% of the spherical femoral head. So, the depth provides a larger articular surface, further improving the stability of the joint. The iliofemoral, pubofemoral and ischiofemoral ligaments, the three most important ligaments, are very strong ligaments, and along with the thickened joint capsule provides a large degree of stability to the hip joint. The structure of the acetabular labrum provides the stability to the joint. It maintains a negative pressure acting like a vacuum seal, and it enhances the joint stability. Let us come to the second part of the lecture, which is on the common problems of the hip joint. The common problems of the hip joint are fractures. So, let us discuss first about the intracapsular fracture. As shown in the figure, the intracapsular fracture may be subcapital near the femoral head, the cervical or transcervical, which is located in the middle part through the neck of the femur, and the basicervical fracture, which runs through the lesser trochanter to the greater trochanter. So, it is near the trochanters. Such a damage is maximum when it is subcapital and least when it is a basicervical fracture. So, these fractures are common in old age patients between 60 to 80 years. The other type of fracture is extracapsular fracture. As shown in the figure, it may be intertrochanteric between the trochanter and peritrochanteric. Intertrochanteric is between the trochanters and peritrochanteric is along the trochanters. Now, these two can be classified under trochanteric fracture. The other type is subtrochanteric fractures, which occurs below the trochanters. These fractures generally occurs in young adult subjects owing to severe traumatic injuries. Arthritis is a bone degenerative disease, and osteoarthritis is the most common form of arthritis that is observed in the hip joint. As you can see in the figure, that the cartilage gradually wears away in case of a osteoarthritic joint. In this figure as well, we can see the cartilage is worn away as compared to the normal situation as indicated in this slide. Now, once it wears away, it results in bone to bone contact, producing bone spars, eventually causing pain and stiffness and restricted movements. The other common form of arthritis is the rheumatoid arthritis. In rheumatoid arthritis, inflammation or swelling of the synovial membrane occurs. This synovial membrane covers the synovial joint. Rheumatoid arthritis results in pain in the joint and as well as stiffness. It may be noted that rheumatoid arthritis is an autoimmune disease. It occurs when the immune system mistakenly attacks the own body tissues. The immune system damages the normal tissue such as cartilage and ligaments and softens the bone. Rheumatoid arthritis also affects the synovial fluid within the synovial joint. The list of references is mentioned here, based on which the lecture has been prepared. Thank you for listening.